Is it up to the pharmacy to ensure that the patient's medication, like their blood pressure, is going to be okay for another six months? Who takes responsibility? If the prescription initially has been written for 6 months, that's the doctor taking responsibility for a 6-month prescription. But if a pharmacist extends it for another 6 months, is it the pharmacist taking responsibility for that patient's medication?
Welcome everybody to my podcast. I'm Tanya Corless, and today we talk about the health issue, or maybe what could happen if you don't understand correctly the pharmacist over the counter. Today my guest is Claire Lynch. Claire is a beautiful lady who is a pharmacist with a huge experience in the pharmacy field, and I hope you will enjoy our conversation today. Okay, Claire. So tell me about your education and tell me about how you decided to be a pharmacist and where you're working at the moment. It's a community pharmacy or hospital pharmacy, and what do you see differences between two?
Okay, so from leaving cert, I did a degree in science and I ended up working in pharmaceutical industry for a few years.
Wow.
So I was working in the quality control lab, which was basically testing drugs to make sure that they were what they said they were. My part-time job when I was in college, when I was younger, was in a pharmacy. I always liked healthcare. I always liked how medication can affect a person in a good way or a bad way, can help with illnesses, can improve a person's quality of life. So when I was working in industry, it wasn't what I wanted. And I looked into going back to do pharmacy as a mature student. So I went back at the age of 23. Or 24. Well, 23 is the age for a mature student. So I was about 24. It was hard. I was still living at home at the time, which was how I was able to manage. I used my savings because it was my second time going back to college. I had to pay fees. So I used my savings from when I was working, plus my part-time jobs. I was always working through college to fund pharmacy. So when I qualified then, I worked in community pharmacy, which is where I've mainly been for the last 10 years, is community pharmacy. I've had a couple of short stints in hospital pharmacy, which is a real eye-opener to see the difference, because there is a huge difference between community and hospital pharmacy. So in terms of the job of pharmacist, I have seen sort of the three main areas that a pharmacist can work in, which is in industry. They work in releasing batches, doing ensuring everything is right for a batch of drugs to be released, and working in quality control. We would be working with the pharmacists in industry to ensure a batch of drugs are okay to go in community pharmacy, and then again in hospital pharmacy.
Well done. So you started working as a pharmacist in a community pharmacy, and then you said you experienced in a hospital pharmacy. So how you can describe one to another? It's an easy or harder work in the community pharmacy, responsibilities in the hospital pharmacy. I know they operate completely different. You basically can't compare one to another from my experience. But at the same time, I knew everybody will have the different experience based on that. So what you can say?
Well, for me, when you're working in the hospital pharmacy, the doctors are right there. If you have a question or a query, or if you need a prescription to be changed, the doctor is right there to do it. Whereas when you're in a community pharmacy, you have to try and ring a hospital. You have to try to get through to a ward. You have to try to get through to a doctor who's on the team of a patient if you've got a query about a patient and their prescription. And that's an awful lot harder. It can take hours to get through, to try to amend someone's prescription. In that respect, then working in the hospital felt like you were more of a team, because you were right in there. The doctors were right there, the nurses were right there, the patient was right there. When you're working in community, it can be a little bit more isolating, because you have to try and contact, if you're trying to confirm medication
from that point, yes, okay, yeah.
If you have to try to get to a doctor
and dose everything, yeah.
You have to, like I said, you have to try to ring, you have to be on hold, you have to email, you have to wait hours for a response, you have to wait hours for someone to get back to you. And in that meantime, you have to tell the patient something. You have to tell them either take that medication and hopefully that's what the doctor comes back with, or don't take your medication and delay your medication because we need to confirm this because the prescriptions are unclear. or what the doctor has said to you is unclear. So there are pluses and minuses on both, but a hospital feels a bit more that you're part of a team, and also that you can try to prepare the patient for going into the community. So you can, if you're lucky, be able to see the prescription before the patient is discharged, to be able to put your own notes on it to say that this medication, like all their regular medication, stays the same, nothing else has changed, or there's been an increase in medication, there's been a decrease in medication, there has been a stop in medication, because all of this sort of little bit of information helps when the patient goes back into the community, because then the community pharmacist can look at the prescription and say, yes, I know now that this medication has been increased, it's not an error, that this medication has been stopped, that's fine, that this is a new medication, that's fine. And it's just clear communication.
Right.
And that's what can be difficult in community. Sometimes the communication isn't as clear
As it should be.
Yeah.
All right. Explain to me one thing. So when you have a customer over the counter, they brought a prescription. Doesn't matter what the prescription for. Matter is they're asking you, okay, I would like to get all the medication. And sometimes the pharmacy can see that maybe it's not sensible for the customer to get all of them. For example, from the history, he can see that some of the medication he already got it. And from your point of view, he still has plenty. Or maybe not reasonable to get again because it's only 4 months kind of. Even the doctor probably prescribe is for 6 months. How the customer will react? The customer fight for it badly, or customer will kind of try to understand what you're saying?
We try to explain. So say, for example, which happens quite a lot, the customer doesn't want to come back to the pharmacy in 2 weeks' time.
Mm-hmm. We can understand why, yeah.
The rest of their medication. And a lot of that is a case-by-case basis. If you know your customer and you know your customer understands their medication,
yes,
you can explain to them, well, these are the tablets and you already have them. So I'm only going to give you a few more to make you up for the rest of the month. So say, for example, I know from their last dispensing, they've got 2 weeks of blood pressure tablets at home. I'm not going to give them another month of blood pressure. I'm only going to give them another 2 weeks to make it up to the month so that all their medication
will be correct.
Will be correct and finished. Sometimes, if you know that this is an elderly patient, that it's carers that look after the patient and look after the medication, and you know that they're not going to understand, we try to explain to the carers or to the family that there's an awful lot of tablets to be given. The patient should have an awful lot of tablets at home. We need them to put aside everything that's at home and try to explain to them. Bring them back to us, put them aside, and just take what I'm giving you right here. And so an awful lot of things like that is a case-by-case basis. It is a case of, do the family, do the carers, do the patient, do they understand that they've got medication at home and they might not need more, or it would be better for them to just bring back everything they've got at home and bring them. Sorry?
For their own safety.
For their own, yes. And that's what it is. And then there would be medication that are controlled drugs. And medication that's controlled drugs, I personally don't really give out more if they're not needed. So if they got a controlled drug last week, I'm not going to go and give them a whole new month of it because it's like, you've already got it.
Yeah.
You know, it's not a good idea to have a lot of medication in the house, regardless of what it is. And the thing about it is as well, at the moment with generic medication, a lot of pharmacies get in different generic medications every month. So the boxes can look different. So although the medication is the same, you might be giving them their blood pressure, the same blood pressure tablets, but they're in a different box, and the patient thinks they're different, and they start taking those as well, because they think that these are different because the box is different. So it is very much a case-by-case basis on the patient and on the medication as well.
Guys, that's very important that not anymore me, the pharmacy, any healthcare, when they explain to you about the medication, they meant only that you have to be care what you're taking, how you're taking, and you need to be very careful about the boxes. They look very similar as generic or as a branded. It doesn't matter. Matter that you need to pay attention what exactly you're taking, how many days. If you're confused, feel comfortable to back to the pharmacy, whatever you are, local pharmacy, or if you pass by and you have medication, you're confused. Don't afraid to pop in and ask the questions or make a phone call. This will be just a job too. Because what the pharmacists are confused sometimes, they're not actually not confused. They just try to not confuse you more from the point, if you're taking more than you need, you can be in a hospital, and who will be responsible? The pharmacist. They try to care about themselves, about you, and try to do the job on a high level standard. Am I right, Claire?
Yeah, it happens a lot. I have seen it. It would happen on a weekly basis, and where you've got patients that have doubled up on their medication because it came in 2 different boxes. And we're always trying to stress and try to say to people to ask us, and we put on labels if medication is, if they're used to getting a medication from one brand and they're going to be getting it in a different brand, we put it on the label to say it's the same. We point it out when we say it to the customer, it's the same. But an awful lot of the time, I suppose with life, people aren't really listening, they're not paying attention, they're just bringing home. And when you have an awful lot, which is, I suppose we call it polypharmacy, when we have an awful lot of medication going to the one customer, you think, oh
my gosh, yeah.
That's why I personally prefer, if there are changes, bring it back to the pharmacy.
Make sure
take it out of the house. Because obviously as well there could be children in the house, and they might pick up something. There could be people in the house that think, oh, that's paracetamol. I'm going to take some paracetamol.
But it's not really. I heard about the new regulation will start on soon from the 1st of March. Mm-hmm. It's about the prescription extending by the pharmacist. So can you just clear this question?
Now, to be honest, I don't know the full information myself.
Okay.
But as it stands at the moment, when a doctor writes a prescription, the doctor can write on a prescription that it's valid for 6 months. And that's the maximum amount of time a prescription is valid for is 6 months. And there's a new directive coming out to say that a pharmacist can extend that prescription to be valid for 12 months
for another 6 months
if they deem it appropriate. Now, that's where, as far as I'm aware, the information has stopped, because I don't know what is deemed appropriate.
Okay.
I haven't come across any of the regulations yet to say, well, it's only X, Y, and Z medication that can be done like this.
Okay. Mm-hmm.
If it's blood pressure, it's up to the is it up to the pharmacy to ensure that the patient's medication, like their blood pressure, is going to be okay for another 6 months? Mm-hmm. Who takes responsibility? If the prescription initially has been written for 6 months, that's the doctor taking responsibility for a 6-month prescription. But if a pharmacist extends it for another 6 months, is it the pharmacist taking responsibility for that patient's medication?
Yeah.
I do understand, and it a lot of pharmacies are quite relaxed if a patient can't get to a doctor. So say if they are... they have to wait 3 weeks, which is quite normal, 3 weeks, a month to get a prescription. They might need another month of prescription and another month of medication. And a lot of pharmacies are quite relaxed with that and quite flexible with that. I don't know how relaxed and how flexible they will be to extend a prescription that long.
Claire, from, again, your experience working over-the-counter community pharmacist, you have helpers like a pharmacy technician. So do you think are they valuable on the premises, or it has to be, in your opinion, has to be more of them and less OTC staff, front of the shop staff, or it has to be maybe 1 or 2 who is needed and you will be relying as much on the OTC staff? As on the pharmacy technician, or it's a different category?
Yeah, I rely a lot on trained staff. I think all staff, no matter what your position was, or whether it's working in the dispensary or working OTC, it's trained.
Okay.
An awful lot of the time I get asked, oh, can I speak to the pharmacist? And an awful lot of the queries are queries that the OTC staff could easily deal with. Because a lot of the time it can be, I have a cold sore. What can I have?
What can I have,
a lot of the time, and I'm being pulled away a lot of the time as well when it's only one pharmacist. There's only one pharmacist. There's only one person that can release medication and say that it's good to go. There's an awful lot of work that only the pharmacist can do.
That's true as well.
So I think that if you have a really good team and a very good trained team, they would be able to step in, and also as well the pharmacist can trust them. I've worked in a lot of situations where I've worked with very good teams and I can trust them because I know that my OTC staff and my technicians, I know that if they're unsure of something, they're not just going to make it up. They will come and ask me.
To confirm something if they're
to confirm
stuck,
something.
yes, yeah.
And I know that they are as trained up. They're probably more knowledgeable. I often get out the front of shop and someone asks me about an OTC,
lost.
and I do be lost because I'm like, I'm not really too sure what OTC products they have in the pharmacy
because you're not
here.
There, you're not
because
there.
That's not where I spend most of my work, and I feel like saying, oh well, actually the OTC girls are here, well, they'll be able to help you a lot more than I will, because they know all the medication that's available that they've got, and they know, and they are trained. All the staff are trained, and a lot of the customers are okay. They are fully aware and they're fine with that. But you do get customers that they'll just want to speak to the pharmacist, and like I said, it's pulling you away from work.
That you doing is more important, and only you and the
that
pharmacy
only you can do, and also increasing risk of error because of interruptions.
That's true. Are you still happy to be in a pharmacy, or maybe you will thinking back to the industry?
It's been a long, long time since I've done industry. Industry is very different in that it's very paper-based. Mostly it would be very sort of paper-based, and you are dealing with a lot of problems. So say if there's a problem in production, or if they get a result in the quality control lab that they weren't expected.
Okay.
It's up to the pharmacist or the qualified person, as they're known as in the industry, to decide, okay, well, this is what you're going to do. This is how you're going to fix it.
Okay.
So again, there's an awful lot of stress. I don't think there is a stress-free job for pharmacists.
I think so, yeah.
Because an awful lot of the time, like, they've got their own deadlines that they have to meet, that they have to get a certain amount of batches of drugs and medication released within a certain amount of time, but then there could be an issue with that, and it's up to that person, that qualified person, to decide, okay, this is what you're going to do. I want the lab to repeat these tests. I want production to go and do this. To
get one another and match But it's kind of the same in the pharmacy as well, because deadlines in the pharmacy existing too, like, for example, paperwork or the blister packs, or even delivering special medication when the person really ran out.
And there's an awful lot more than just whoever's in the shop at the time.
Yeah. Okay.
So, and an awful lot of customers, I'm not too sure if they fully realise that, because there's emails coming in, there's phone calls coming in, there's people who have ordered medication
and check them in and
already
placed,
There's people who are standing there and want their medication. They don't want to call back, or they don't want to wait. So there's an awful lot of different aspects, and you're being pulled in an awful lot of different situations, which is why it brings it back to your team that you've got. Because you need to be organised, and you need to be able to focus, and you need to be able to, I suppose, ignore the stuff that you don't need to be involved in.
From your experience, how often the pharmacist or technician or any staff who works in the pharmacy has to be, retrained or reviewing all those SOP or regulations, or what's the pharmacy doing to upgrade the staff who's working there?
So stuff like that should really be done on a yearly basis.
Okay.
So SOPs and then SPCs.
SPCs, yeah, as well.
Which are like the regulations of the drugs that come from the drugs companies. They do be updated, and it does say it on it. It says when they get updated, whether it's what year it's getting updated. But they would probably be updated every year, 2 years. So it's constant.
Constant.
Yeah.
So when you're working in the medical field, healthcare, you have to upgrade yourself regularly. So what about those CPD courses that everybody who works in the healthcare has to cover up? So how many CPD courses you have to, as a pharmacist, go up during the year?
Well,
again, approximately, just because I know it's worked differently for everybody.
There is a website for pharmacists, the IIOP website, and it has CPD courses on it, and you can do as many or as little as you want in a year, but you are going to be called up every 5 years.
Okay. Randomly.
And you could be called up to show your CPD in a paperwork form, or you might be called up where you have to go in and do OSCEs. So these are face-to-face with an actor who's acting as a patient and you're getting observed. Yeah. And you have to do that along with an exam. And again, that's randomly.
Okay.
So I think...
Did you have this experience?
Not the face-to-face with the OSCEs. I've had it twice on paper, if you like.
Okay.
And so you have to do maybe about 10 different scenarios. So you have to like CPD courses, which is just a situation. So you might say that, I work in hospital. I was asked to look up this drug and I didn't know how to look it up. Okay. And you go around what you did to educate yourself and how you figured out this problem, basically. And you have to write it all up. Okay. And you have to do about 10 different situations like that cover about 5 years, because you get called every 5 years.
That is actually very interesting. But also I would love to explain to the customers who knock to your pharmacy and sometimes confused. GMS prescription, a newish one. A DPS prescription, can you give kind of brief description about the schemes that's existing at the moment?
So the main schemes, so GMS, so those are the patients that are on medical cards. So depending on their age, if they're over 70, there is a levy per item, which is €1, up to a maximum.
That's not bad.
Yeah, up to a maximum of €10. And that's per couple. And if they're under 70, it's €150 per item or €15
per couple.
It
would be family or couple, because sometimes
I'm thinking of couple over 70, but under 70, couple, it would be family. But that covers not all medication. It is medication that has a code. Is what we say, special code. So basically, it's medication that the HSE has agreed that they are going to cover the cost of this medication, and the customer is only going to pay the levy on it, the tax. Okay. Not all medication is covered. If that's the case, it's still perfectly prescribable, legal medication, but the payment of it is to the customer.
Okay.
And if they want the medication, they're going to have to pay for it privately.
Extra it. Okay.
Yeah. And then similar to that would be DPS. The DPS is the Drugs Payment Scheme. Everybody is really entitled to that if you've got a PPS card. So if you were a resident in Ireland, everybody is entitled to a DPS card. And that'll limit the amount per household to €80.
It's not bad, actually.
Which is not bad. It's come down an awful lot the last few years.
Yes, yeah.
So it's not that much, and it goes up to, and then with kids, it depends on whether they're in full-time education or not.
Age as well. Okay,
yeah, so it'll cover kids, but it'll get a bit when they get to kind of leave insert age, whether they're in full-time education, it's for another couple of years. If they're not, they're on their own. And again, it's the same thing. It's whether there is a code on their medication. The vast majority of medications have codes. But for example, one that sticks out just because it's got very popular over the last few years is melatonin, that it is prescribed for sleeping, and it isn't covered under this scheme. It's not covered on medical card. It's not covered on DPS. And so say, for example, the customer already comes up to €80, so they pay their €80, but they're also on melatonin, they'd have to pay that extra.
Separately. And it's expensive, for example.
It's expensive enough.
So only for the melatonin to sleep, yeah.
And that's just an example of something.
Yes.
A lot of things that aren't covered would be what we would class as unlicensed medication. And unlicensed medication isn't illegal medication or anything like that. It's just medication that the drugs company basically have not applied for a license in Ireland because Ireland is too small. We're too small a population for that drugs company to go through the regulations of getting a license for it. Yeah. And so it's perfectly normal legal medication, except it's not considered licensed in Ireland, and not some medication is covered, but the majority of unlicensed medication is covered. And then we've got, so that sort of, those two schemes would cover a lot of people.
Lots of people,
and then we've got the long-term illness. So long-term illness is a section of, basically, as it says, a long-term illness. I don't think there are any plans to expand the illnesses that are covered. The main illnesses that would be covered.
Recently, for the last few years, what they covered, what doesn't, or the covered medication there.
The covered medication.
Okay.
But you might think, say, for example, you might think an asthmatic is long-term medication, but it's not considered for the scheme as an LTI. So the main ones are probably like diabetes, type 1 and type 2 diabetes are long-term medications. So those patients will get medications for those illnesses covered completely for free.
Right.
So
that is good if you like to drink.
But if you are on it, so if you are a diabetic, you will get your diabetes medication for free. But if you are a diabetic and you are on an antidepressant as well, the antidepressant has got nothing to do with the diabetes, so that's separate. So it'll only cover medication to do with that.
Related to the issue.
To do with that illness. And there is no, like I said, you have to be diagnosed.
And proved.
Like, more, it would be from your doctor that would do that would do that paperwork. And the DPS would be the patient. They would apply for a DPS card, a drugs payment scheme. They would apply for that themselves. Like I said, there's no regulations really, other than that you are living in Ireland.
Right. But DPS, for example, is it still the customer can apply through the pharmacy, or is it changed?
They can get an emergency. So say, for example, you were on no medication today and then something happens tomorrow and all of a sudden you're on a big, huge medication. The pharmacy can give you all that medication for €80, but it's only valid for a couple of months. You'll still have to go and apply and get your own card. So it's very, very easy. It's mydps.ie, a website. And I think everyone should apply for
and have
a DPS card and have it, just to have. When you apply for a card, it's valid for 10 years. So it's of no harm. There's no, you have to have your PPS number, I think, and a household bill or something like that. It's very, very easy to apply and to have it. Because an awful lot of people as well, when they get an emergency DPS, did you forget that they have to finish off the application? And it's only valid for a few months. And then after those few months, if you haven't applied for it, the pharmacy can't apply again.
For it,
And unfortunately, you will have to
pay for it.
Pay upfront for everything.
The customers sometimes, before it used to be anyway, will go from the emergency, but eventually they forget whatever else happened. And by end of the month, the technician, the pharmacy basically suffering from that because the card doesn't approved, but the person paid only a particular amount of money that actually doesn't cover the all medication that's been dispensed, if you talk about the just money. So is it still kind of going that way, or is it any system that's basically
all the dispensing systems should flag up whether a customer has a valid
or not valid
card or not valid card. If you have applied for a card on behalf of the patient, most people, like most workers, will put in, they put a date in on the person's file to say they're 3 months, they have to apply for it so that by whatever date, so that the pharmacy can go and ask, have you got your card?
Okay.
Did you finish off the application? Otherwise, unfortunately, the pharmacy won't know until they get their rejects.
Yeah.
So when they claim for their monthly medication, like their monthly dispensing
claims,
on their claims, it can come up as a reject because the customer, say the pharmacy had applied for their DPS card, their emergency DPS card, but that was 4 months ago. So now 1 month has gone past.
Nothing happened.
So you would go to that customer and hope, have you got your card? Because then you can able to reclaim.
claim. Okay. At least the pharmacy can do something about that, right?
But it's up to the pharmacy to really kind of keep track.
I know, but the pharmacy probably will happy to do this just to keep the customer in.
Yeah.
Otherwise, you'll lose money anyway if thinking from that, and the customer could be changed and go somewhere else, whatever. So, but I heard one story. The girl who on the GMS card, okay, I don't remember what medication she was taking, but it was something cream for psoriasis. She said, I came to the pharmacy and I have a GMS card. So one day they said to me that this is medication, it doesn't cover by medical card. It's unlicensed. Printed license, because it's, people confused about how it works.
Yeah.
It's unlicensed. And for example, she said to me it was expensive. She paid approximately €30 for this little tube of ointment, I think it was. And next month, whatever, she back again for the same things. And that time they give it to her and says it's only cost blah, blah, blah. And she been confused. I said, hold on, why the previous months you give it to me only what I have to pay for? It's the same medication. This explanation that she got out of the staff, it's been like, oh my God, that's what we had at the time. You've been prescribed, so we give it to what we had. So, and she been confused, why you didn't order for me that would be covered. So how people should react, or the pharmacist may be dealing with, or has to be maybe changed, I don't know. But it's kind of unfair to the GMS patient who are supposed to be get for €1, for example, this medication is to pay for €30.
A lot of the time, it's the medication you can get at that time.
So that's the fact.
Especially when it's unlicensed, a lot of pharmacies will only order in when it's needed. You don't order in because it's expensive, and it's maybe it's not prescribed that often. You're not going to have something sitting on your shelf that you don't need.
Everything.
So you will only order in when it's wanted.
Okay.
And then it's what's available at that time.
At the time.
Yeah.
So the customer need to understand that sometimes you come to the pharmacy, and pharmacy shouldn't have, not must to have, everything, all the medication on the shelf in one example. It has to be something what you go up at the moment, and you're happy to pay your pain. If not, so you can go and try different pharmacists, or you just, it's nowadays it's the way how it works.
Yeah, it's at the moment with just so many shortages.
That is a part of it.
That's a huge part of it. And it's just, and it is, well, there is a medication that is covered on the medical card, but I can't get it. I can only get the one that isn't covered. So the choice then is to and that's the reality. Unfortunately, it's like, the customer can go around different pharmacies.
And
have you got any of this stock?
It could be the same probably story.
Yeah, and it'll probably be the same information, or they can get the one this month, and hopefully next month, if they need it again, the medication that is covered on the medical card will be
different. Yeah. Anyway, Claire, thank you very much for coming. Thank you very much for all the information. I hope I'll see you again, and I hope also you enjoyed.
Thank you. I did.
Thank you very much.
Thanks.